Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're getting into something pretty critical, the surgical management of obstructive jaundice. It needs a really structured approach.
It really does.
So basically what happens is something blocks the bile flowing out of the liver, physically stops it.
That's right. A mechanical blockage.
And it's not just, looking a bit yellow. The sources point to some serious usual suspects. Gallstones. That's choledochylithiasis.
Yep. Common one.
Or, much more concerning, these strictures may be from cancers,
Yeah.
like pancreatic head tumors, cholangiocarcinoma.
Exactly. And that's why you need to understand how critical this is. When that bile flow stops, pressure builds, bile backs up.
Okay.
And you're immediately looking at potentially catastrophic multi-system problems. Think severe sepsis, that's cholangitis we're talking about.
Right.
Liver dysfunction, major clotting problems. Your kidneys start to fail. Nutrition just plummets.
Wow. Okay.
So, our plan today is to basically walk you through the blueprint. We're drawing heavily on the European and British guidelines here.
A standard approach.
A very standard, very disciplined sequence.
Yeah.
We'll go from diagnosis, getting that quickly, through stabilizing the patient urgently, and then on to the definitive fixes, the interventions, and surgery.
Okay, let's start right there at the beginning, the initial assessment. Before any scans, what info do they absolutely need?
Well, first up is a really thorough history. You're asking about specific things. Pain, fever, that intense itching called pruritus, any unexplained weight loss, night sweats.
And risk factors too, I suppose.
Oh, absolutely. Previous abdominal surgery, history of heavy drinking. That all matters.
And then the physical exam. What are they looking for? Jaundice is the obvious one.
Yeah, you'll see the yellowing. But they're hunting for signs that things are really bad systemically. Is there a lump, a mass you can feel? Signs of shock, low blood pressure suggesting sepsis?
Okay.
Or visible signs of maybe internal bleeding, fluid buildup like ascites, signs the clotting isn't working.
Right, and those signs tie into the lab work.
Directly. You need the full picture fast. So that's a full coagulation screen, kidney function tests, and critically, the liver function tests, the LFTs.
That tells you bilirubin levels.
Exactly. Direct and indirect bilirubin, plus key enzymes like ALP, ALT, AST, gives you a fingerprint of the liver damage. And here's a really crucial point for managing infection.
Oh.
If you even suspect cholangitis, that bile duct infection, you absolutely must get blood cultures before starting any antibiotics.
Got it. Culture first, then treat.
Precisely. And that urgency flows right into the imaging plan. It follows a strict order, a hierarchy.
So what's step one on the imaging ladder?
First line is always ultrasound. It's fast, it's everywhere, pretty good for spotting if the bile ducts are dilated or if there's an obvious mass.
But it has downsides.
The big one is it's operator dependent. The quality really relies on who's doing the scan.
Okay, so if the ultrasound shows dilation, or maybe they're worried about cancer.
Then you move up. Second line is usually CT scan and MRCP. That's magnetic resonance cholangiopancreatography.
Right, MRCP. Now, I heard you say MRCP is really good and non-invasive. Why use CT then, or the more invasive ERCP later?
Good question. MRCP is fantastic for seeing the bile ducts themselves, the anatomy. It gives you detail almost as good as the invasive ERCP, but without the risks. So often preferred if you suspect malignancy.
The CT.
CT is vital for staging cancer. It shows if the disease has spread, if it involves blood vessels nearby. MRCP isn't as good for that broader picture.
Okay, that makes sense. They serve different purposes.
Exactly. And this brings us to a really important policy point you need to grasp. Those invasive procedures, ERCP, endoscopic retrograde cholangiopancreatography,
Mouthful.
isn't it just? Or EUS, endoscopic ultrasound. These are basically safe for when you think you're going to do something therapeutically right then and there.
Not just for looking.
Precisely. Doing an ERCP just for diagnosis is strongly discouraged. The risks, like causing pancreatitis or worsening sepsis, just aren't worth it if you don't plan to immediately place a stent or drain the blockage.
Yeah, okay, you don't want to poke around and make things worse if you're not fixing it at the same time.
You got it. Risk versus benefit.
So the blockage is confirmed, the patient is likely dehydrated, maybe their clotting is off, maybe they're septic. How do you stabilize them? Get them safe for whatever comes next.
All right, stabilization is crucial. It's the bridge to definitive treatment. It's pretty rigorous. First, fluids. Lots of IV fluids.
Or the dehydration.
Dehydration, yes, but also to protect the kidneys. They take a big hit when bilirubin is high, very prone to acute injury.
Okay. Fluids first. What else?
Second, fix the clotting. Obstructive jaundice stops you absorbing vitamin K properly.
Which you need for clotting factors.
Exactly. So if their INR, that clotting measure, is high, they need vitamin K. If it's really bad, maybe fresh frozen plasma. You have to address bleeding risk before any procedure. It's huge.
And what about just making the patient feel better? I hear that itching, the pruritus from the bile salts building up, is just unbearable.
Oh, it's incredibly distressing. Yeah, that's managed with drugs like clostridium. It binds the bile acids in the gut. Or sometimes antihistamines can help a bit.
Okay.
And critically, stabilization also means starting broad-spectrum antibiotics straight away if you suspect cholangitis. Something like piperacillin tazobactam. Start immediately, then adjust based on those blood cultures later.
And nutrition.
Yep, ongoing nutritional support, often adding in those fat-soluble vitamins they can't absorb, A, D, E, K. That starts right away, too. Patients are watched like hawks, often using sepsis scoring systems. If things look bad, it's straight to the ICU.
Okay, this seems like a really critical holding pattern. But when does it tip over? When does it become a flat-out emergency needing intervention right now?
The trigger is active infection and signs of organ damage getting worse. If the patient has acute cholangitis, they need that biliary system drained, and quickly, ideally within 24 to 48 hours.
And how do you spot that clinically?
You look for the classic signs: fever, jaundice, pain in the upper right abdomen. That's known as Charcot's triad.
Charcot's triad. Got it.
If they have that plus low blood pressure and confusion or altered mental state, that's called Reynolds pentad.
Okay, pentad is worse.
Much worse. That's profound sepsis, maybe shock. You need to act immediately. Decompression is urgent.
Let's talk about that decompression. What's
Yeah.
the go-to non-surgical method?
First choice generally is ERCP with stenting, especially if the blockage is distal, lower down the bile duct near where it enters the intestine. Things like stones or tumors near the sphincter ovati.
And the stent itself. Doesn't matter what kind they use.
Oh, absolutely. The guidelines, particularly the British ones from BSG and NICE, are very clear on this. If it's cancer that can't be cured and you're aiming for palliation.
To relieve symptoms long-term.
Exactly. Then you should use a self-expanding metal stent or SEMS. They have a wider opening and stay open much longer than plastic stents.
So plastic stents are less preferred.
For long-term palliation in cancer, yes, they block up quickly, meaning the patient needs more procedures, more costs, more risk. Plastic stents are really only for very short-term drainage or maybe some benign conditions.
Okay, metal for malignancy palliation. But what if ERCP doesn't work? Maybe they can't reach the blockage.
Good point. If ERCP fails, or if the blockage is very high up in the liver, near where the ducts branch, what we call a hilar obstruction, then you need alternatives.
Like what?
That's where you might see EUS-guided drainage using ultrasound from inside the stomach or duodenum to guide a drain. Or PTC, percutaneous transhepatic cholangiography. Basically, sticking a needle through the skin, through the liver tissue, directly into a bile duct under X-ray guidance, and placing a drainage catheter. Often drains externally initially. It's often the way to go for those really high, complex blockages.
Right, so ERCP first, but PTC or EUS if that's not possible. What about actual surgery? When do they cut?
Surgery comes in if those drainage methods fail, or for certain complex strictures, or sometimes it's palliation if other methods aren't suitable. And of course, if the goal is actually cure.
So what surgical options are there?
It depends entirely on the problem. For a benign stricture that just won't stay open with stents, the sort of gold standard bypass is often a Roux-en-Y hepaticojejunostomy.
That's creating a new path for the bile.
Precisely. You surgically connect the bile duct higher up directly to a loop of the small intestine, the jejunum, bypassing the blocked segment entirely.
And if it's cancer, they think they can remove.
Then the goal changes to curative surgery. If it's a suitable pancreatic head cancer, that means the Whipple procedure, a huge operation, a pancreaticoduodenectomy.
Wow.
Or for certain bile duct cancers, cholangiocarcinomas, it might involve removing parts of the liver. But these are massive operations. They absolutely have to be done in specialized high-volume centers. HPB units, hepatopancreaticobiliary units.
That makes sense. Expertise matters there.
Mm-hmm.
This brings us to the decision-making process itself. The sources really emphasize the multidisciplinary team, the MDT. What exactly are they weighing up?
The MDT is crucial. It brings together the HPB surgeons, the oncologists, gastroenterologists, radiologists, pathologists, everyone. They look at the whole picture.
Not just the scan.
No. How fit is the patient overall? What other medical problems do they have comorbidities? How far has the disease spread? What's the likely outcome? Are we aiming for a cure? Or is this about extending life comfortably, palliation? Is the patient strong enough for major surgery, or are less invasive options the only realistic path?
It's a complex balance.
Yeah, very much so.
And this ties into something really interesting from the guidelines about planning before surgery. You mentioned BSG guidelines advise against doing an ERCP just before planned surgery. Why skip the drainage?
Yeah, that's a key strategic point. If you know definitive surgery is planned and imminent, doing an ERCP right beforehand carries risks.
Like infection.
Exactly. Procedure-related complications, infection, pancreatitis. You potentially make the patient sick right before their massive curative operation. Why take that risk for minimal gain if you're going to fix the blockage surgically anyway?
So you avoid potentially seeding bacteria into the area you're about to operate on.
That's the thinking. The guidelines push for rapid referral if criteria are met, like jaundice plus sepsis or kidney injury or a palpable mass. Get them to the specialist unit quickly for consolidated assessment and management, potentially straight to surgery without a preceding ERCP.
Okay, so we've really traced this structured path, starting non-invasively, stabilizing urgently, using specific drainage techniques based on guidelines, and then considering highly specialized surgery, all coordinated by an MDT.
That's the essence of it, a very systematic approach. But, connecting this to the bigger picture, saving the patient acutely with drainage or surgery is just the first step. The long game is just as important for their quality of life. Meaning you have to keep monitoring them. Stents block or migrate. Obstruction can come back. That might mean repeat ERCPs or PTCs down the line.
Right. It's not necessarily a one-and-done fix.
Often not, especially with stents.
So we've drilled down into the acute phases, the stabilization, the intervention. But maybe the final thought to leave everyone with goes beyond that immediate crisis. It's not really over once the drain is in or the surgery's done, is it?
Not at all. That's a crucial point. What does that patient need long term? You have to think about surveillance watching for cancer recurrence if that was the cause. Managing chronic problems that result from altered bile flow, like difficulties absorbing fat-soluble vitamins, ongoing nutritional support, and importantly, psychological support too. Dealing with the diagnosis and the aftermath is tough. That post-acute long-term care is absolutely vital. The initial rescue is just the beginning of the journey for many of these patients.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.